Hello, I'm Umair Khalid. I'm one of the social media editors at JACC Cardiovascular Interventions, and it gives me great pleasure to welcome Dr. Urado Roman for this interview. Dr. Urado Roman, thank you so much for joining us today.
Thanks, it's a pleasure for me.
Thank you. So we are very excited to feature your publication titled Rotational Atherectomy, Lithotripsy, or Laser for Calcified Coronary Stenosis, the roller coaster EPIC22 trial. So could you please begin by outlining the methodology of the study? I understand this is a randomized trial, which is what the interventional community really wants to hear, because there's a lot of data on this topic, but not much randomized data. So we're very excited to see what you did.
Yeah, thanks for the question. Yeah, the main reason of doing this is this thing you have said. We don't have enough randomized evidence comparing advanced plaque modification techniques. And for this reason, we designed this prospective multi-center randomized clinical trial in which we compare these three advanced techniques, rotational atherectomy as the reference technique against lithotripsy or laser in moderate or severe calcified lesions. The primary endpoint was the percentage of stent expansion by optical coherence tomography measured by an independent core lab. And we used an intention to treat non-inferiority analysis using, as I said before, the rotational atherectomy as the reference group. We randomized the patients immediately after observing moderate or severe calcification in the angiography. And we highly recommended an OCT before the plaque modification technique and immediately after. But the OCT was mandatory at the end of the procedure after implanting and optimizing the drug-eluting stent, because we need to analyze the primary endpoint that was the percentage of stent expansion. We pre-plan the flow in case of need of a second technique according to the reason of this need, just to maintain a similar sample size between the three arms. We included all significant lesions in vessels from 2.5 to 4 millimeters in diameter in all scenarios or clinical scenarios, stable coronary disease and also acute coronary syndromes, excluding patients, the culprit lesions of STEMI, cardiogenic shock, and cardiac arrest. This is the methodology of the design, more or less.
Thank you so much for your response. On that note, could you elaborate on the key findings of the study?
Yeah, of course. After analyzing everything, the baseline features, the angiographic features, and also the procedural features were similar between the three arms. And we observed a significant need of a second technique rate in the three arms from 10 to 15%, similar in the three arms, but for different reasons. In the arm of ROTA, the main reason of need of a second technique was that the lesion was undilatable after using ROTA. And in the arms of lithotripsy and laser, the main reason of the need of a second technique was that the lesion was uncrossable. We obtained similar success rate and MSA, minimal stent area, in the three arms, and a low complications rate in the three arms without significant differences, probably because of this low complication rate, but with a trend having less perforations with IVL, with lithotripsy. Regarding the primary endpoint, IVL achieved this non-inferiority compared to ROTA in terms of stent expansion by OCT in all the analyses. And laser did not achieve this non-inferiority compared to ROTA in terms of stent expansion in the intention to treat analysis. But when we did the analysis by the last technique used, or in cases without crossover, we did not observe these differences. So this is difficult to interpret because this significant crossover between the techniques, but these are mainly the results.
Thank you so much, Dr. Urado Roman. This is so helpful. Thank you for sharing these results, and especially use of imaging and everything. This is such a well-done study. Now, how would you or any interventional cardiologist translate these findings into real-world practice, you think? And I know that this is not specifically studied in this trial, but if you could share your opinion from your expertise, are there specific types of calcified lesions, like nodular versus concentric versus others, which are more suited to one type of atherectomy compared to other?
Yes, that's a very interesting question. Yeah, it's important to have randomized evidence, of course, but I think we will continue selecting the device according not only to this data, but also because of the patient clinical profile, the lesion characteristics, the calcium pattern with imaging, of course, the resources of the center, the experience of the operator, everything is important. So the first conclusion I would have with this study is that you cannot treat 100% of calcified lesions with only one technique. They are complementary, and the device selection is quite important. And in terms of the type of classification to choose one or another, as you said, we don't have yet the data. We are doing some sub-analysis of this trial. We have different results of previous registries. I think that lithotripsy has increased exponentially because it seems to be safer. It's the data we have, and it's simple. So probably these are the reasons of being useful in different calcified patterns, but probably not only in different patterns regarding the calcium, but in long lesions, in uncrossable lesions, as we see in our trial, rota and laser should be included in all our algorithms, and also the combination of these techniques in cases, for example, with very severe concentric calcified lesions. Rota is unbeatable to cross the lesion, but probably cannot modify the thick or deep calcification, and should be combined with IVL. And we described in a journal some years ago the first rotatripsy technique, also eccatripsy, and we should not forget orbital as well. That could be a nice option in nodules, in tortuosity, in osteal lesions. And laser, to finish, sorry for extending, laser could be the first option in peristem calcification, or in cases in which we have calcium and thrombus that is not so unusual.
Right. Perfect. Those are great points. Thank you so much for sharing, Dr. Radarman, and congratulations on your work. Take care.
Thank you very much. Thank you very much.